Hello again, ladies and gentlemen. This will be a talk on endometriosis, and this is an update to a lecture I gave 2 years ago in July of 2016. There are a few new facts that we know now about endometriosis. Nothing that's really going to alter how you approach a possible endometriosis question on a test on pelvic pain. However, I do think that they are worth going over, and so I do want to do an update to this lecture. It's also nice because I've got better technology now and I can make this lecture in widescreen now instead of that little boxy format that I used to use. All right, so if you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video or on the I button on the upper right-hand corner up here, and it should link you up. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. And if you subscribe, you'll have access to some of my premium videos in which I go over case studies, how to formulate differential diagnosis and treatment plan, things that will come in handy for you for clinical practice, and as you get ready to study for USMLE Step 3, which, as you probably are aware, contains a section that is open-ended, non-multiple choice, where you need to choose from a list of things of what you're going to do next in a patient. So it actually simulates, it's called the clinical case scenarios for the USMLE. So I think that those resources will help you for that. Thank you very much in advance for your consideration. All right, so we have a vignette here. We've got a 28-year-old woman who presents to your clinic complaining of cyclical pelvic pain for the past year, pain that kind of comes and goes over a long period of time. She says that it's remained constant. It's about a 4 out of 10 constantly, but seems to get predictably worse in the days leading up to her period. She denies any pain on urination and has only had 2 bladder infections in her life. Past medical history is unremarkable. She's got no STDs, no history of STDs, no significant family history. She's never had any surgeries. She's not on any medication. She denies drinking, smoking, or drugs. She's monogamous with her fiance and says that occasionally she has some mild discomfort during sex. She has never been pregnant as far as she knows, but is considering pregnancy after she gets married next spring. Her cycles are regular, around every 26 to 28 days. Physical exam, abdomen soft, non-tender, non-distended, mild pelvic pain and palpation. Vulva and vagina are normal. Speculum examination is unremarkable. On the bimanual exam, it reveals uterosacral nodularity, adnexal tenderness, and the uterus, which is retroverted. There are no masses. Okay, so 2 things should be going in your mind. A differential, which is very important because that is going to give you a list of things that you want to do next. So if you're taking step 3, well, anytime, but you need to be thinking of your differential diagnosis. So what's our differential diagnosis here? Well, her chief complaint is pelvic pain. So when we're thinking pelvic pain, the number one thing that should come up, you should have a very low threshold of suspicion. In anyone who comes in with pelvic pain, any woman who comes in with pelvic pain, you should be thinking ectopic pregnancy. So immediately you need to know that you've got to get a urine pregnancy test, no matter what. So even if she says that she doesn't have sex, even if she's a nun, I don't care. You get a pregnancy test on a woman of reproductive age who's got pelvic pain. Okay, and keep a nice wide age range for your idea of what pelvic pain or of what reproductive age is. So I would say anything from 10 or 11 all the way up to 60. You're never going to get sued over getting a urine pregnancy test, but you will certainly get sued if you don't and you miss it and you cause a miscarriage. So very important. What else? So another thing that's very common in women, especially if you work in the ER, you see this all the time, who have pelvic pain is a urinary tract infection or a bladder infection. So this is probably not the case here because she doesn't have any pain on urination. But sometimes the pain can be really mild. And even though this is chronic, it's still something that's so common that you want to rule it out. So you want to get a urinalysis. I might as well just bring this up here. Okay. And then another thing, even though she has no history of STDs, it's possible to have an STD and not really know it because it's mild. And if that doesn't get treated, then there's the possibility that you could have pelvic inflammatory disease or a tubo-ovarian abscess. And that can certainly cause pain. Now, usually that's, especially with tubo-ovarian abscess, that's going to be associated with a high fever. Pain is usually a little bit worse, but that's a possibility on our differential. It's a little bit lower, but it's a possibility. So you'll want to get CBC, and you'll want to get vaginal and cervical swabs, just to cover all your bases. So we got a CBC, urinalysis, urine cultures, vaginal and cervical swabs, and so these are all pending. The CBC and urinalysis are within normal limits. We got the urine pregnancy test that was negative. So of course, what's going to be number one on your differential? You get this vignette on USMLE. What's number one on your differential? It should be endometriosis. I put in all of the possible signs that you would see with endometriosis on here. So a cyclical pelvic pain. If you hear cyclical pelvic pain over the course of months, you really need to think endometriosis, because it's one of the few things that causes ongoing pelvic pain that tends to get worse at certain times of the month, usually in the days leading up to menstruation. Another thing that we see with endometriosis is this right here, dyspareunia, pain on intercourse. So that's another thing that you want to ask any woman with pelvic pain. Does the pain get worse during sex? Do you have any pain during sex? If that is true, then that leads us to suspect endometriosis, because that's so common with that. Some other things that we see here on physical exam is uterosacral nodularity, which is extremely common with endometriosis. I wouldn't say it's pathognomonic, but it is certainly, if you see it in the test, that should clue you off. As a matter of fact, it's so common, a lot of times the test won't tell you that because it's kind of a buzzword. Just general adnexal tenderness, and then this retroverted uterus. So all of these three things that I put on this bimanual exam, these are all associated with endometriosis. And there are no masses. However, as we're going to see with endometriosis, you can have masses, especially masses around the ovaries. So your next step then, since you're suspecting endometriosis, everything else is either pending or is normal, you're going to get a transvaginal sonography. And the transvaginal sonography will visualize those nodules on the uterosacral ligament. And that, again, just lends itself to a diagnosis of endometriosis. So at this point, you could pretty much say that you have a presumptive diagnosis of endometriosis. However, the definitive means to diagnose endometriosis is going to be laparoscopy. But at this point, we could start treating the patient as though she had endometriosis. As we're going to see, you can get into using NSAIDs, GnRH agonists, etc. Okay, so we are going to go over the pathophysiology of endometriosis, which is poorly understood, but there are some theories, and so we'll go into those. I don't expect that you'll be tested on any of those theories because, we don't really have any definitive idea of the pathophysiology, and it's quite possible that there may be a variety of different ways that you can develop endometriosis. And no one theory really gives us a fully satisfactory answer. We'll talk about the epidemiology and risk factors. We kind of already went into the presentation, but we'll get a fuller picture of that. We'll talk about the workup and then the treatment. There are medical agents, medications, and surgical treatments, and we'll get into those. So endometriosis, by definition, is the presence of endometrial glands and stroma outside of the normal location. This is a hormonally dependent disease. So more estrogen equals more symptoms of endometriosis. And that is why it's going to be cyclical, because a woman's levels of estrogen and progesterone, they cycle with the month. And so because of that, you're going to have cyclical pain. Now, the pain may be ongoing, but if you ask a woman with endometriosis, she'll typically tell you that the pain gets worse coinciding or slightly before her periods. Endometriosis presents chiefly in reproductive age women. So, most women will start having symptoms. They'll start suspecting, that something's wrong, usually in their early 20s, and then it just goes on. And it's so chronic that when a woman presents with endometriosis, often it'll be, a year or several years of history, and maybe it's just getting worse. But there's generally, months and months of pain rather than, this just started last week. So look for chronic pain in a reproductive age woman. It's cyclical. As I said, the most common presenting symptom is chronic pelvic pain. And there are a lot of things that can cause chronic pelvic pain, but this should be towards the top. When you've got a woman who's got months of pelvic pain, maybe even just mild pelvic pain, like our patient in the vignette, plus 3 or 4 out of 10, mild pain, but cyclical. It should be considered on the differential diagnosis of ongoing pelvic pain, as well as infertility and subfertility. So you have a woman that's having difficulty getting pregnant. When you're doing your workup for infertility, you need to consider endometriosis as a possibility. So you get a whole gynecologic history. If pelvic pain is part of her history, even if the pelvic pain itself was not ever severe enough for her to get checked up for it, you should consider endometriosis, because endometriosis pain may not always be severe enough for her to actually want to go in and get checked out. So it could be subclinical in that regard, to the point where she doesn't go in until she starts having difficulty getting pregnant. We'll go into why endometriosis can cause fertility issues in a little bit. Endometriosis is not the same thing as adenomyosis, but some of the symptoms might overlap. So I did a video on adenomyosis. You can watch that if you want. Adenomyosis is similar insofar as you have endometrial tissue that is in a place where it shouldn't be. But with endometriosis, that tissue can really be anywhere. With adenomyosis, the endometrial tissue, it stays in the uterus, but it gets into the myometrial layer. And so you have endometrial tissue in the myometrium. And that causes like a confluently enlarged uterus, as opposed to endometriosis, where that tissue can really be anywhere. And so as you can imagine, some of the symptoms, particularly pelvic pain, will overlap, but it is not the same thing, and you will note that when you do your imaging. So the pathophysiology of endometriosis. You will not be tested on this on the USMLE because we don't exactly know what causes endometriosis. It may be a variety of causes. We've got a variety of theories, and each of them explains some aspects of endometriosis, but not all of them. So it's quite possible that more than one of these may be at play. It's possible that none of these are at play and it's something entirely different that we don't even know. And so for that reason, you're not going to be tested on this on the USMLE, but it's good to understand some of these things because it gives you a more holistic understanding of endometriosis. And there is some evidence behind each of these. So far and away, the most common explanation of endometriosis, probably the one you learned in medical school, is this retrograde menstruation theory. Now, normally when you menstruate, if you're a woman, what's going to happen is that you get peristalsis of your uterus that pushes the contents that are to be menstruated out the cervix. And that is good because then it gets out of your body. Now, some women have issues with peristalsis of the uterus. They have what may be characterized as hyperperistalsis, where it's just contracting too hard, or dysperistalsis, where it's just not in a coordinated way. And so what can happen with those is that you can get menstruation backwards. Now, you might be asking, if you don't have a really good grasp of anatomy, well, where's it going to go? Well, remember that on either of your fallopian tubes is a hole. Those fallopian tubes open to the peritoneum, and that is exactly how you can get an ectopic pregnancy that happens in your peritoneum. Now, most ectopic pregnancies are going to be in the fallopian tubes, but you can get an ectopic pregnancy that lodges in your peritoneum, and it's through those holes that the egg would get out of. And remember, that hole is important because those fimbriae, which are at the end of the fallopian tubes, they grab an egg from the ovary. Remember, the ovary is not attached to your reproductive tract. And so the fimbriae grab an egg and pull it down into the fallopian tube. So there is a hole there. And the idea behind retrograde menstruation theory is that when you have this disordered peristalsis, it's going to push the menstrual contents out the opposite end. And at that point, those endometrial fragments can then get out of the uterus and into the peritoneum. And then at that point, you're going to have a huge problem on hand, because once those endometrial fragments get into the peritoneum, they take up camp on the peritoneal mesothelium, and they can develop a blood supply. And now that endometrial tissue is alive and can respond to hormones. And remember that endometriosis is a hormonally dependent and hormonally sensitive condition, as we're going to see when we get into treatment. Now, unlike normal endometrial tissue, these endometriotic implants, these implants, ectopic implants of endometrium, they create some different chemicals, some different enzymes. So they have the capability of expressing aromatase, which, remember, converts androstenedione to estrone, E1, which can then be converted into other estrogens. And it also has a hormone you don't need, or an enzyme, you don't need to remember this, called 17-beta-hydroxy dehydrogenase 1. And that particular enzyme converts estrone to estradiol. And that estradiol plays an important role in the production and conversion of your prostaglandins, and that's ultimately going to cause pain. I don't have a picture of it, but that whole cycle where arachidonic acid ultimately gets converted to prostaglandin E2, this is going to have a positive feedback. So arachidonic acid gets converted into prostaglandin E2 in part by the cyclooxygenase 2 enzyme, COX-2, and that actually induces aromatase. So you kind of have this positive feedback loop where you get the production of aromatase, that aromatase creates estradiol, and then estradiol induces COX-2, and so you're creating all of these prostaglandins, and that's probably what's behind the pain in endometriosis, are these expressed enzymes. Now, normally in endometrial tissue, you have a different kind of 17-beta-hydroxy dehydrogenase, and that's type 2. And that actually inactivates estrogen. So it's a different kind of enzyme that is active in these endometrial implants, and that's probably why you get all of this pain associated with endometriosis that's not present in normal endometrial tissue. So that is the retrograde menstruation theory. Another thing that lends credence to the retrograde menstruation theory is the fact that women who have outflow tract obstructions, so things like a transverse vaginal septum or a unicornuate uterus, where you have this rudimentary horn of the uterus that is capable of menstruating but has nowhere to go. These women have a higher prevalence of endometriosis, and it's probably because they have a harder time getting their menstruated tissue out. And so where's it going to go? Well, it's going to go the only way it can go, and that's going to be backwards. So we do have a higher prevalence of endometriosis in women with outflow tract obstruction, and that lends credence to the retrograde menstruation theory. Now, another theory is this lymphatic and vascular spread, and this may explain the finding of endometrial tissue in these very unusual sites like perineum and groin. I've even heard of endometrial implants being in the lungs, and that sounds really bizarre, but it makes a lot of sense when you consider that endometrial cancer spreads through the lymphatics, and that one of the primary places endometrial cancer can metastasize to is, in fact, to the lungs. So there's very little experimental evidence behind this lymphatic and vascular spread behind endometriosis, but it may explain some of these more stranger places. I've heard about it in the eyes and all sorts of weird places. So that may be behind that. Another one is the coelomic metaplasia, and this suggests that the parietal peritoneum is actually pluripotential tissue and can undergo metaplastic transformation to tissue that's similar to normal endometrium. So, because the coelomic epithelium is the progenitor to the ovaries and to the Müllerian structures, it can explain ovarian endometriosis, why you can get endometriosis in the ovaries. Now, that could also be explained by retrograde menstruation, where it can then lodge onto the ovaries, but coelomic metaplasia can also be an explanation behind that as well. It may also explain why you can get endometriosis, and this is going to be a shock to you, why you can get endometriosis in men. Okay, remember that we all have this same germline tissue, and there are instances that have been documented where men have chronic pelvic pain, and it's found that they have tissue that's similar to endometrial tissue. And so when what we found in these men that have these symptoms strangely consistent with endometriosis is that they were at one point exposed to estrogen. So most men, even though they may have this coelomic metaplasia, even though they may have it, they don't really ever get any symptoms from it because remember, endometriosis is a hormonally sensitive condition. You need to have estrogen. So these men who did have these symptoms, all of them were exposed at some level to estrogen. So maybe it was because, for some reason they weren't metabolizing estrogen, so they had liver failure, or maybe they were taking estrogen-like medications, or really anything that can cause a hyperestrogenic state. Some of these men actually went on to develop pelvic pain and were found to have endometrial-like tissue. So this is really only explained in the literature. I've never seen a case of this personally, but that, again, is another possible explanation. Another is very similar to that. It's the induction theory, and that just says that exposure to estrogen induces transformation of certain tissues to endometrial-like tissue. So in vitro studies have demonstrated the potential of ovarian surface epithelium to transform to endometrial tissue in the presence of estrogen. And then another is this immune dysfunction, which just suggests that there may be a localized impaired cellular or humoral immunity that may be behind this. Very complex. I'm not going to get into it. So these are some of the theories behind endometriosis. You're not going to be responsible for this on any test, I promise you. The epidemiology of endometriosis. So there is an estimated prevalence of surgically diagnosed endometriosis reported at 1.6 per thousand. Now, not all women who we treat for endometriosis, and we can make a presumptive diagnosis of endometriosis, get surgery. So the actual prevalence of endometriosis is probably significantly higher than 1.6 per thousand. You could call that subclinical endometriosis or just non-surgically diagnosed endometriosis. Surgery and biopsy is really the only way to definitively diagnose endometriosis, but in practice, it is diagnosed very commonly clinically. And then evidence does indicate that the prevalence is highest in East Asians and then followed by whites and then blacks. I don't know where Hispanics fall into it, but typically when it comes to this paradigm where you see East Asians, then whites, then blacks, or vice versa, Hispanics tend to fall somewhere between whites and blacks, but I'm not sure. This is all I could find in the literature. I didn't find anything for prevalence, particularly among Hispanics. So what are some of the risk factors for endometriosis? Well, we don't really know, but what we have found is that there is familial clustering. Now, this isn't any kind of Mendelian pattern, but there is increased incidence in first-degree relatives. So there 5.9% of sisters of women with endometriosis will have endometriosis themselves, and in women who have endometriosis, 8.1% of them will have mothers who have endometriosis. And we also know that women with severe endometriosis are far more likely to have an effective first-degree relative. So familial clustering. Genetic mutations and polymorphisms, there are no genes that we know of that always cause endometriosis, but there are some candidate gene mutations that have been considered as a risk factor. So just because you have a mutation of that gene doesn't mean you're going to get endometriosis. We just see a higher incidence of these gene mutations in women with endometriosis. And those candidate genes are EMX2, which is responsible for reproductive tract development, probably not a coincidence, and then the famous PTEN gene, which you see in oncogenesis. Another risk factor is anatomic defect. We already talked about that. That's an increased incidence in women with outflow tract obstruction. So the transverse vaginal septum, imperforate hymen, the non-communicating uterine horn, which you see in the unicornuate uterus. So for this reason, diagnostic laparoscopy is suggested at the time of corrective surgery because you can investigate for some of these anomalies and correct them if you need to. Some other things are environmental factors, TCDD and dioxins, which are these chemicals that are pollutants from industrial processes. These waste products have been associated with endometriosis, and the idea is that it can contaminate foods and then upregulate transcription of various genes. This isn't real definitive evidence behind this. It's just, again, sort of theory. And then caffeine and alcohol use. Incidentally, we do see a decreased prevalence of endometriosis among women who smoke. That's not to say go tell your women with endometriosis to go start smoking, but there is a slightly decreased prevalence of endometriosis among smoking women. And then there's also a decreased prevalence of endometriosis among women who exercise regularly. But there's kind of some confounding with that because, women who have chronic pain, do you think they're really going to want to exercise a lot? Probably not. So that's really difficult to gauge. So the presentation of endometriosis, far and away the most common presenting symptom is chronic pelvic pain. That pelvic pain can be localized, but often will radiate, and it can radiate to the back or to the leg. And really, it just depends on where those endometrial implants are. You don't necessarily know just based on where they have pain, because pain can be kind of a fickle thing. But the pain is not always just localized to the pelvis. But if you ask the woman, where's the pain the worst, she's definitely going to point to her pelvis. So that is the most common presenting symptom or feature. The pain symptoms themselves can be cyclical, or it can be chronic, or it can be, sort of cyclical superimposed on chronic. I would say that's probably the most common way it presents. So like in our patient with the vignette, she's kind of got this chronic background of pain. She's, mild pain all the time, but it gets worse with her periods. That's a very common presentation. So most women, when you talk to them, will tell you, I'm constantly in pain, but it just really gets worse with my periods. Maybe goes from a 3 to like a 6 or a 7. The cause is unclear, but as we said, it's probably related to those increased cytokines and prostaglandins due to the abnormal expression of enzymes in the endometrial implants. Please note that pain is not correlated with the extent of the disease, so all the places that the endometrial implants are, but rather the depth of the invasion where the endometrial implants are. So it's the depth of the invasion that correlates with the pain, not the extent of the disease. Dysmenorrhea, very, very common. Typically, the pain will precede the menses by a couple days, and it's less responsive to NSAIDs and combined oral contraceptives than we might think. So let's say you got a woman coming in, she says she's got pain with her periods. Well, the top of your differential diagnosis should be primary dysmenorrhea. There's other things we're going to work her up for, and I did a talk on dysmenorrhea. But primary dysmenorrhea is the most common cause of dysmenorrhea, of pain with menses. Normally, with women who have primary dysmenorrhea, we give them NSAIDs, ibuprofen, and they respond pretty well to that. Or if they don't, you can give them oral contraceptives, and they respond pretty well to that. Dysmenorrhea, when it's in conjunction with endometriosis, because it's so hormonally responsive, and because the tissue is abnormal, because it's producing these abnormal enzymes, it tends to be less responsive to NSAIDs and combined oral contraceptives than we would otherwise suspect when you have a patient with just garden variety primary dysmenorrhea. So consider that. Dyspareunia, remember that is pain with intercourse. And women with endometriosis will often, have chronic pain, but when they try to have sex, that pain just is worse, and sometimes it can be so unbearable that they can't even have sex. So this is associated with seeding at the uterosacral ligament or at the rectovaginal septum, less associated with ovarian involvement, but it can be associated with any of those things. All of those things can get disrupted with sex, and so that's what can cause that to cause pain. Very commonly, dyspareunia may develop out of the blue, so she may have had this kind of chronic endometriosis pain for some time, and then she suddenly started having pain with sex, and she hadn't had that before. And that probably owes itself to the fact that endometriosis is a progressive condition. It gets worse with time, typically gets worse all the way until she goes through menopause, and now she's not making estrogen like she used to, and that tends to cause the endometriosis to almost go away completely. So endometriosis tends to progress, and so the dyspareunia can come on later on down the road, whereas she was having chronic pain before, now she develops dyspareunia. Dysuria has been described. It is less frequent, but it is associated with cyclical urinary frequency and urgency, which may coincide with her periods. Obviously, when we think of urinary frequency and urgency, pain with urination, we think of urinary tract infections. We think of maybe interstitial cystitis. So important to get a culture and a urinalysis. Obviously, the culture is going to be negative, but you may see some hematuria, and that's probably because of endometrial implants in the bladder or in the urinary tract. So dysuria has been described, but it's not as common as dysmenorrhea and dyspareunia by far. Defecatory pain is another one, not as common, but interesting because you can have defecatory pain with endometriosis, and it can also be associated with constipation and diarrhea. So you got pain with pooping, and you've got blood in your stool, or you've got constipation and diarrhea. What are some things you think of? Well, you think of inflammatory bowel disease. If there's not blood, you think of irritable bowel syndrome. All of those things would be a possible explanation, but it can actually be endometriosis behind that. And this suggests rectosigmoidal involvement, and certainly if you have endometrial implants in the rectosigmoid, you can get bleeding because that tissue is fragile. And so that can cause a positive stool Guaiac test. So if you have a patient with chronic constipation, diarrhea, defecatory pain, certainly you're going to be working them up for the potential for inflammatory bowel disease. One of the things you're going to do is get a stool analysis or at least a stool Guaiac test, and you would see blood potentially in the stool. So it's endometriosis is a possibility. Certainly in most people who have defecatory pain with blood in the stool, it is going to be a GI cause behind it. But if they have chronic pelvic pain, or if they've got a history of infertility, then you do need to consider the possibility of endometriosis behind it. It can cause defecatory pain, blood in the stool, etc. Okay, another one that is definitely common is infertility and subfertility. About 20 to 30% of women with subfertility have been found to have endometriosis, even if they did not have the pain behind the endometriosis or it wasn't significant enough for them to have gone in before. This probably owes to distortion of the tubal and ovarian architecture. And it can also be behind, what also can be behind it is endometrial implants on the ovaries, which can interfere with folliculogenesis. So lots of things with endometriosis can contribute to that infertility and subfertility. And a lot of times, you've got women who have fertility issues. You do diagnose them with mild subclinical endometriosis, which then comes to light. And then one more thing is intestinal or urethral obstruction. I want to focus on the intestinal obstruction. So this can occur because endometrial implants can take up camp on the small bowel, on the appendix, on the cecum. And when it gets into that tissue, if if you have an obstruction and you've got endometrial implants on the tissue transmurally, if you were to do a CT, as you would if you've got a patient with suspected bowel obstruction, endometriosis, those endometrial implants can look almost identical to a malignancy of the bowel. So in those cases, you're typically going to go on to do a laparoscopy, get a biopsy, and that will differentiate it from a primary cancer. But again, another way that endometriosis can masquerade, so it can cause an intestinal obstruction. As far as a urethral obstruction, again, it's due to those implants. If you do have a urethral obstruction, it's going to present with, sort of an urgency, frequency, and it can actually progress to post-renal failure if it's not treated. So urethral obstruction is another possible presentation, but far and away the most common: chronic pelvic pain, dysmenorrhea, dyspareunia, or a woman with infertility, subfertility. So when you do your physical exam, visual inspection should be normal. So the external genitalia, all going to be normal. You don't really see anything from the outside. Now, when you go in a little bit more invasively, do your speculum exam, typically that's going to be normal. However, you can have some endometriotic implants on the vagina, definitely less common. But when you do see them, there'll be occasionally blue or powder red lesions, which when you manipulate them will easily bleed. So looking, at the cervix, posterior fornix of the vagina, you may see lesions. Definitely a minority of endometriosis patients. I read in one study it's around 14 or 15%. So a minority, but definitely, you've got a patient with chronic pelvic pain, you've got to be doing, your speculum exam, your bimanual exam, and so that's one thing that you might look out for, these lesions. Certainly, you need to go further to differentiate these lesions from other things. But blue powder red lesions that easily bleed. Not a lot of things that cause that other than endometriosis. Bimanual examination can vary greatly. So the most common things I put in boldface here: uterosacral nodularity and tenderness, very commonly associated with endometriosis. If you're taking a multiple choice test and you hear uterosacral nodularity, it's endometriosis until proven otherwise. So remember that the uterosacral nodularity is just endometrial implants on the uterosacral ligament, which is a ligament that connects the uterus, kind of fixes it in place against the sacrum. So that's a very common place for those endometrial implants to go, and certainly when that happens, that area is going to be tender, and as mentioned, that is part of the cause of the dyspareunia. So you may know the nodularity, but a lot of times when you do the bimanual examination, that's really going to be uncomfortable for the woman. Another thing that you will notice in a lot of cases of endometriosis is the fixed retroverted uterus. So normally when you do a bimanual exam, what should happen is that when you stick your two fingers through the cervix and then up into the uterus, the give should come a little bit more anteriorly. So your fingers should naturally kind of, with the give, go in an anterior direction. If that give kind of goes backwards, posteriorly, that suggests a retroverted uterus. Now, in some cases, you'll be able to kind of flop the uterus back and forth, but when it's fixed, you won't be able to do that. So the uterus is just kind of stuck backwards. Fixed retroverted uterus is also seen very commonly with endometriosis. Now, not all women with endometriosis have a fixed retroverted uterus, and certainly not all women with a fixed retroverted uterus have endometriosis. You kind of just have to take this into consideration with the presentation. You may note an adnexal mass. This mass can be mobile or it might not be mobile, but when you feel a cystic mass in conjunction with symptoms consistent with endometriosis, this is the famous endometrioma. And then finally, a fixed, firm posterior cul-de-sac is possible. Remember that the posterior cul-de-sac is just that potential space between the uterus and the rectum, and so you might note that as well. In general, pelvic organ palpitation sensitivity, the sensitivity and specificity of that for endometriosis really varies and can be unreliable. So just because there's pain, it doesn't mean she's got endometriosis. Again, you have to take all this stuff in consideration with all of the other things. You've got a very big differential when it comes to pelvic pain. And for some women, you run into, it's just any kind of bimanual examination is painful for them. And I'm not denigrating their pain, but for some women it's just uncomfortable. They just don't like the bimanual examination. So you can't rely on that to give you a diagnosis of endometriosis. It would just be consistent. Pain with the bimanual examination is highly consistent with endometriosis, but not all women with the pain on the bimanual examination have endometriosis. So the sensitivity and specificity vary considerably. Your workup is always going to include a CBC, a urine HCG looking for the possibility of an ectopic pregnancy, urinalysis and culture because this is pelvic pain. You want to rule out a UTI, you want to rule out interstitial cystitis, and then vaginal and cervical cultures primarily because we're worried about the possibility of pelvic inflammatory disease, which is another of the common causes of chronic pelvic pain. Once you get all that and you're still thinking endometriosis, then your next step is going to be imaging. And the first modality of imaging that you're going to use is transvaginal sonography. And this is, in fact, the mainstay in evaluation of symptoms associated with endometriosis. There are other approaches that you can use, the saline infusion sonography, the transrectal sonography. You can also get transvaginal sonography with color Doppler, but the first step that you should do is just a regular old transvaginal sonography, and here you are looking for, and I'll be showing you pictures, you're looking for endometrial implants, which you should be able to see, especially if they're on the uterosacral ligament. Diagnostic laparoscopy is the definitive means of diagnosing endometriosis because there's the potential of getting a biopsy with that. However, in most cases, we diagnose endometriosis clinically and will attempt medical management first. It's only if the medical management fails that we'll then go into laparoscopy. And that's the means by which we can get a definitive diagnosis. But the first step, as far as imaging goes, is going to be the transvaginal sonography. CT and MRI can also be used, but definitely much lower down our list. So these would be uterosacral nodules. Now, it's really hard when you're using transvaginal sonography, really any sonography, to visualize ligaments. And especially the uterosacral ligament, because it sits right kind of behind the uterus, and it's really just tissue that kind of looks confluent to the tissues surrounding it. So really the only time you're going to be able to actually visualize this is when there's something wrong with it, namely when you have nodules. So here you can see, I'm not sure if this is the same nodule, if these are two different nodules, looking a little bit more closely. But this nodule here measures by about 1.5 centimeters by about half a centimeter. So appreciable, you know that you would be able to feel this. So sometimes, though, you can't feel them, and so doing the transvaginal sonography, you may be able to see ones that you can't feel, but I would say you'd probably be able to feel this one. But like I said, transvaginal sonography is really good for finding nodules that you can't otherwise feel. So these are nodules. These are endometrial implants that are visualized with laparoscopy. You would not be able to see this with ultrasound. So the lesions can vary in color. You can see here they're like red and brown, and that color comes from blood. The brown is like oxidized blood. But so like the lesions themselves are most commonly like white or red in color. The morphology, as we're going to see, can vary. They can be little smooth blebs, or they can be more stellate. They can be superficial or deep. So they have a variety of appearances. This is on the anterior aspect here of the uterus, and these are very stereotypical in appearance. Although you got a little bit of like bleeding here. So it's kind of hard to appreciate. But this is much closer up. This is very, very characteristic. This is what a lot of them look like. You see kind of here like a reddish appearance. Sometimes they can look brownish black. But this is these characteristic endometrial lesions, these implants here. And you might characterize these as blebs, for lack of a better word. You can also see, which is notable here, is the really robust blood supply that's coming up here. So you can see the little arterioles coming to these implants. All right, and so here you see more endometrial implants. This is again on the uterus. You can see here what appears to be an intestine, but you can see here that these nodules are a little bit larger, and again, sort of red in appearance. This is an endometriotic ovarian cyst. You can't really see the ovary really well here, but if you were to puncture this cyst, which would probably not be a good idea, but sometimes they just break, you would get this stuff coming out of it, and this is just oxidized blood. But this is where it gets its name, the so-called chocolate cyst, because this stuff kind of looks like chocolate coming out of it. Like I said, usually these are on the ovary, and now they're always on the ovary, but it can be really difficult to tease this out from the actual ovarian tissue. So invariably, you're going to need to take out a little bit of ovarian tissue when you take this cyst out. Now, if she's done bearing children, then you can certainly just take the ovary out with it. But in a lot of cases, you got to be really careful if she wants to preserve fertility, because the more ovarian tissue you take out, the more you're going to affect her fertility. So this is the endometriotic ovarian cyst, or the so-called chocolate cyst. Typically, you're going to be able to feel these. They can get to be pretty large. And this is another chocolate cyst, but it's a little harder to appreciate here because it's not punctured, so you can't see the actual quote-unquote chocolate coming out. And then this is endometriosis on the uterosacral ligament. So this is something that we would have been able to appreciate on transvaginal sonography. Certainly if it's big enough, you might be able to feel this. But this is behind the uterus, on the uterosacral ligament, and also the ovarian fossa. So the differential diagnosis, gynecologic causes for chronic pelvic pain, or pelvic pain in general, but pelvic pain that tends to be more chronic. Pelvic inflammatory disease, so this can be tubo-ovarian abscess, salpingitis, endometritis. These tend to occur along with some degree of fever or infectious signs. Definitely the tubo-ovarian abscess, you're going to run a pretty high fever with that. But this is something that needs to be taken into consideration. Look for a history of STDs, especially STDs that were not treated. A hemorrhagic ovarian cyst, again, can be part of endometriosis, or it might not be. But this can also be a cause of pain. Ovarian torsion tends to be very acute. So this is not, ovarian torsion does cause pelvic pain, but it's acute. But also very severe pelvic pain. So that was not consistent with our patient that we saw. This you would diagnose with sonography. But this is more acute, so it's got to be pretty hard to diagnose ovarian torsion with endometriosis, or to confuse ovarian torsion with endometriosis. Primary dysmenorrhea, so that's just painful periods without any underlying cause that we know of. A degenerating leiomyoma, I talked about in my fibroid talk. What that is, it's just a fibroid that's overgrown its blood supply. That can cause some pain. And then I should have probably put this at the top, because this is the one that we're always concerned about, the ectopic pregnancy, but also very easy to rule out with the urine pregnancy test. 9 non-gynecologic causes. We kind of went into all of these, how endometriosis can masquerade as these things, depending on the symptoms that it presents with. But a chronic UTI, Interstitial cystitis, so these would both be if there's pain on urination, which we see can happen theoretically with endometriosis. Renal calculi, again, can cause sort of pelvic pain, pain with urination. Some women are predisposed to urinary tract infection and just get it a lot. And some people are predisposed to developing kidney stones, for some reason. It can masquerade as GI disorders. Again, another cause of sort of pelvic, like abdominal pain, lower abdominal pain. IBD, IBS, diverticulitis. Diverticulitis tends to be more in older people who develop diverticulosis over time. And then musculoskeletal disorders. The medical management. So the treatment will depend on various factors. And in fact, some women who have endometriosis, it's subclinical and they don't even need treatment. But most of the time when a woman comes to you with pain, they're going to want something for that pain. They're going to want some kind of treatment that's going to help with that. So the treatment really just depends on a variety of factors. So the specific symptoms that she's having, the severity, where is the pain? And very importantly, what's her desire for future fertility? Obviously, if she doesn't have any desire for future fertility and she's got severe endometriosis, really bad pain, and we have, we're pretty sure it's endometriosis, then we could do a bilateral hysterectomy, salpingo-oophorectomy. So that is a possibility. So we do want to know what her desire is for fertility because it may just be easier to manage this surgically and get this dealt with once and for all. I have a cousin who had endometriosis. She had the pain. She had, unfortunately, a lot of difficulties trying to get pregnant. Just decided, I don't really care to have kids. She wound up adopting a little girl from Guatemala and decided to just, be done with it, get the total hysterectomy done. And now I believe she's probably on estrogen supplements, but she doesn't have any issues with endometriosis anymore. So some of the medical agents include NSAIDs like ibuprofen and naproxen, combined oral contraceptives. Those are usually the things we go to first. Those would also be the things that we would go to with primary dysmenorrhea. Progestins, androgens, GnRH agonists, or you may also hear referred to as GnRH analogs. We'll get into why we use those. And then aromatase inhibitors like anastrozole or letrozole. So NSAIDs are usually the first line of therapy. And typically, we use this in primary dysmenorrhea. So you may not even know that the woman has endometriosis. She might just say she's got pain with periods, and you don't even necessarily need to go any further into that. Or maybe she just doesn't have any other symptoms that lend itself to a diagnosis of endometriosis. So you may just treat her with NSAIDs on a presumptive diagnosis of primary dysmenorrhea. But remember, as we said, women with endometriosis versus women with primary dysmenorrhea, the ones with endometriosis will tend to be less responsive to NSAIDs because with endometriosis, the tissue is making those prostaglandins in bulk. And so NSAIDs aren't going to be enough in most cases. As a matter of fact, and I probably should have written this out, but according to the American College of Obstetricians and Gynecologists, if a woman has symptoms consistent with endometriosis, but you don't know, you haven't done surgery or anything, if NSAIDs don't work, it doesn't resolve her pain satisfactorily, but you go on to use the GnRH analogs, and that works, that is actually diagnostic for endometriosis. So you wouldn't even need to do surgery at that point. The combined oral contraceptives are the mainstay for most patients with endometriosis. The reason that this is useful is because it disrupts that estrogen and progesterone cycle. And so there may be some ongoing pain, some mild chronic pain that continues with combined oral contraceptives, but she won't get that spike, that monthly spike in pain that comes with her period. So that can be very useful for a lot of women. And so most women with endometriosis will be managed with NSAIDs and combined oral contraceptives. Some of the other things that we can use if NSAIDs and oral contraceptives are not satisfactory, we can use progestins. So progestins come in a lot of different flavors. So and there are different ways that they can be administered. So what progestins do is they antagonize the estrogenic effects on the endometrium, which results in decidualization of the endometrium and then ultimately atrophy. And that's a really good thing because it's the endometrial implants that are behind the pain. So the progestins are really nice because you can administer them in a variety of different ways. You can administer them orally. You can administer them as a depot shot, and that would be like the Depo-Provera. You can also administer it with an intrauterine device. So remember, these progestins, this is just non-oral contraceptives. So you've probably prescribed these in women without endometriosis. Most of the time when you're prescribing them, it's for contraception. So, as you know, there's a variety of different ways that they can be given. I would say that the most common is going to be increasingly is going to be the levonorgestrel intrauterine device. This is the Mirena. You put it up through the cervix. It kind of lodges onto the lower uterus, and you can leave it there for 5 years. And that's really nice because these women then don't have to take pills. So you can do that instead of the oral contraceptives. Others include the Depo-Provera, as I already talked about. The downside to that is that they have to take it as a shot, and then there's also the adverse effect of decreased bone mineral density. Norethindrone is taken orally. It is very effective, especially when given with leuprolide, which is a GnRH agonist. There's also the ulipristal, also known as ELA. This is a selective progesterone receptor modulator, and it also is given orally. Another one is mifepristone. This is also known as the RU486. It is an abortifacient. This is not FDA approved for endometriosis, so definitely disregard this for any test-taking purposes. However, clinicians have found that this is very effective, when used, but it is off-label. So cross that out if you're studying this for test-taking purposes. You will never use that. But if you did, remember you need to get a pregnancy test before you administer it because it is an abortifacient. So androgens can also be prescribed, and androgens suppress the LH surge. And it creates an anovulatory state, and that results in decreased estrogen, which also would cause endometrial atrophy. Now, androgens are not used as much as they used to in the past because of the adverse effects that come from them. So think of anything that causes polycystic, or anything that would be a symptom of polycystic ovarian syndrome. Remember, polycystic ovarian syndrome is where the ovaries are creating androgens in excess. So basically, that's going to be what you would simulate. So they can get acne, they can get hirsutism, they can get dyslipidemia, they can get elevated liver function tests, voice deepening, mood swings, hot flashes. So for that reason, we tend to not give these anymore because of the adverse effect profile. But occasionally you will see these given out. This includes danazol, I would say is the most common one. The GnRH agonists are very commonly used in endometriosis that's refractory to contraceptives and NSAIDs. And what the GnRH agonists do, and you would think, okay, well, GnRH, doesn't that cause you to make more estrogen? And yeah, kind of. But remember, it has to be pulsatile GnRH. And if we're giving GnRH in a constant way, which is not pulsatile, then that's actually going to suppress estrogen. So it interrupts that pulsatile GnRH secretion from the anterior pituitary, and that will therefore decrease ovarian steroidogenesis and sex hormone creation. And that basically creates a pseudomenopausal state. Interestingly, GnRH agonists have also been found to decrease COX-2 levels, which remember is behind the creation of those chemicals which cause pain. So the prostaglandins and so forth. So this includes things like leuprolide, goserelin, nafarelin. These latter two are not, I've never seen them prescribed personally, but I'm also not an OB, so, take that with a grain of salt. But this is, The naproxen is interesting because that can be given as a nasal spray. Leuprolide or Lupron, that's given as an intramuscular depot. So these are very, very effective. As a matter of fact, it came out recently in the literature that if you give a GnRH agonist along with an aromatase inhibitor, which we're going to talk about next, that actually decreases the risk of endometriosis recurrence when they're given postoperatively. So that can be very useful to you. Aromatase inhibitors are second-line therapies, and aromatase inhibitors include anastrozole and letrozole, and they basically just reduce the conversion of precursors into estrogen. So obviously, you can understand how that works. I'll just add here that there is the concept of something called add-back therapy. And you might, if you're working, with women with endometriosis, if you're, an OB resident or on your OB rotation, and you see women with endometriosis, you may see that they're given estrogen. And you might be wondering, well, why are we giving estrogen to a woman who we're giving medications to reduce her estrogens? And the reason is because of adverse effects. So what we're really worried about with women we give any of these things to is we're worried about decreased bone mineral density, because remember, estrogen helps strengthen your bones. And so that's why we see in postmenopausal women, their bone mineral density declines. And we're worried about that. If we're giving anything that reduces estrogen, we're worried about bone mineral density decreases. And then, all the other things that having low estrogen levels can cause. So vaginal dryness, hot flashes, and so forth. So the idea with this add-back therapy is that we can give some estrogen and get it up to the highest amount possible to reduce adverse effects, but also not trigger pain. So you can give estrogen in small amounts below a certain threshold. And it's going to be obviously a gynecologist who's going to know how to do this. And you can prevent the endometriosis symptoms by not giving it too high, but also you can prevent some of the adverse effects by giving it in a sufficient quantity. So you're kind of trying to find a balance. So the way you can give estrogen to someone who's already on anti-estrogens, you can give either norethindrone or you can give transdermal estradiol. So that's add-back therapy. It's usually used when you're giving some of the more powerful modalities like GnRH agonists that induce the hyperestrogenic state. Some of the things that we can do surgically include lesion ablation with adhesiolysis. Now, if you ever scrub in for a laparoscopy for endometriosis, you'll probably see the surgeon going through and smoking out those little lesions. It hasn't really been shown that that burning off the endometrial implants actually is effective in reducing pain or severity, quality of life, improving quality of life for women with endometriosis. So it's probably an older practice that's just been retained, but nothing's ever. There haven't been really any studies that have shown that that's actually effective. And as a matter of fact, I would think that's probably a bad thing because, it can, ablating those lesions can probably lead to adhesions. And so you're probably just creating more problems down the road. And it really hasn't been shown to be effective. But that is part of the surgical management, for better or for worse. Endometrioma resection certainly is going to be necessary. If you do feel a mass and you do see the endometrioma on imaging, you'll need to resect that. Presacral neurectomy, I don't really know a whole lot about, but obviously you're cutting off those nerves, which presumably are going to transmit the pain signals. I don't know how effective it is, though. Far and away, and you need to know this for boards, the most definitive surgical management is going to be a hysterectomy with bilateral salpingo-oophorectomy. So in other words, you're just taking everything out. You're taking out the uterus all the way down to the upper cervix. You're taking out the fallopian tubes, and you're taking out, most importantly, the ovaries. Why do you need to take those out? Because those make estrogen. You take all that out, it's got a really, really, really successful profile in treating endometriosis. Now, obviously, you can only consider this in women who are done bearing children. Now, a lot of these women, as I mentioned about my cousin, they have so many problems with getting pregnant that a lot of them have kind of given up, sadly. So you will find a lot of women with just ongoing, real problematic endometriosis. They're going to throw their hands in the air and say, you know what, I'm going to go adoption, or I'm going to use a surrogate, or something like that. I just need an end to this. And so that is usually the profile of the patient where you're going to be managing this surgically. So, a proposed treatment algorithm for endometriosis. So, remember that if you've got a patient with symptoms suspicious for endometriosis, you need to get a history of physical and labs and a transvaginal sonography. Now, if you are treating her pain, if you're coming at this from the perspective of pain, it's going to be a little different than how you treat coming at it from the perspective of infertility, but generally we're going to be at some point addressing both. So if we're dealing with her pain, if the pain is minimal, you can just treat this expectantly. So if she says, I really don't want to be on any drugs, that's fine. If the pain's minimal and she can bear it, that's fine. We're going to write a note in her chart, endometriosis likely, but she doesn't have to be on medications if she doesn't want them. If it's mild, then we're going to go towards sort of in a progression. Start with NSAIDs and oral contraceptives. If that doesn't work, you can move on to progestins or GnRH agonists. Remember that if the pain is not satisfactorily treated with NSAIDs or oral contraceptives, but you go on to treat with GnRH agonists and that does resolve the pain, that, according to ACOG, is a presumptive diagnosis of endometriosis. You don't even need to do surgery. That's very specific and sensitive for endometriosis. If the pain is moderate or severe, interfering with her quality of life, unbearable, or if the pain has not been satisfactorily treated medically, then you go on to do surgery. You'll do laparoscopy. At that point, you can make a definitive diagnosis. You can do excision, ablation, or adhesiolysis. Now, if you're coming at this from the infertility perspective, remember that you need to do a workup for infertility. That's going to include a lot of things. It's going to include imaging. It's going to include, different hormone levels. Obviously, you're going to be looking at the man too, looking at the sperm count. You're going to be looking at both parents, at their chromosomes, see if you can find any translocations. Big infertility workup. I talk about infertility in the OB section, so you can go back and look at that. So one of the things you can do is a laparoscopy if she's got symptoms suspicious for endometriosis. What we can do with the laparoscopy is we can find any anatomic issues and see if we can correct that, and that may help with the infertility. Otherwise, empiric therapy for patients with endometriosis that are having fertility issues, you can use clomiphene, which is going to help with ovulation. And you can also try an intrauterine insemination. Would be a way that you could go about it. Now, after laparoscopy, so postoperatively, if she's under 16 years of age, and that's not common to see endometriosis that young, you would do oral contraceptives. And the reason is we really want to avoid some of those more powerful drugs in really young women. If she's over 16, you can do GnRH agonists or combined oral contraceptives. And if she's an adult, you can do any approved medical therapy. So really, main point here is under the age of 16, stick to oral contraceptives. If there's a recurrence of the pain that had been previously satisfactorily treated, you would adjust medical treatment, or you can do a definitive surgery if childbearing is complete. And that is all I have for you. If you have any questions, please write me a note below.